All right, we're gonna get started. I'm Aria Fallah. I'm a epilepsy surgeon at UCLA Hospital in Los Angeles.
I'm Sumeet Vadera. I'm a epilepsy neurosurgeon at University of California in Irvine. Our talk is going to be on epilepsy surgery treatments. We're going to basically talk about this together, and our thought was we'll kind of go through these slides, essentially give our own thoughts about each major point, and then any questions, please feel free to ask them at the end. All right, so just to get started, the basic treatments for epilepsy are what you see here. So oftentimes the first step is to attempt medications. Often you can do 2 to 3 medications with the goal to hopefully stop seizures entirely. Oftentimes with patients, that is all that is needed to better control seizures. When a patient has failed 2 to 3 medications, we often recommend then referring to a level 4 epilepsy center where additional monitoring can be done and potentially you could be considered for a surgical intervention. And then diet, of course, is a third option for treatment.
So we know that from all comers, everyone with epilepsy. So first of all, epilepsy is incredibly common. So 1 in 26 people will have epilepsy. And 2/3 of them will be controlled with medication alone. And when we talk about medications, the likelihood of a first medication working is about 50%, then probably another 10% for the second medication. But very quickly, we know that more and more medicines are not the answer. There's about 20, 30 different anti-seizure drugs out there. And you certainly don't need to try each one because we know beyond the first two, the likelihood of more medications working is very low. So very quickly, you want to ask your treating epileptologist or neurologist, am I a candidate for epilepsy surgery? Unfortunately, sometimes both Dr. Vadera and I will see patients that are on many, many medications before they get to us. So one of the very important things from this talk is to make sure that you know or you're aware of your surgical options.
Yeah, I can't tell you how many times patients have come to my clinic and said, I've had seizures for 30 years and no one has ever told me that, there's even a surgical option available. And so I'm really happy that you're here, and my hope is that we can bring some new information to you.
Yeah, and surgical treatment is not new. It's been around for over a century. Extremely safe at places that do this a lot. But we do have a problem in this country and many other countries getting patients to surgery. And there's also a lot of even physicians that are not trained, even neurologists that may not refer you in time. Just as an aside, my medical school, and similar to many other medical schools, we spend 1 day learning about epilepsy, and the only thing we were told about was medications. So it's not uncommon that your doctor may not even know about surgical options. So definitely inquire.
Yeah, absolutely. Yeah. This, I think, is a really, really important fact. We really want to kind of, I hope that you leave here and this is beaten home, is that epilepsy surgery is not a last resort. I have patients who come in and they say, having brain surgery is terrifying, which I understand. I would rather take medicine forever, and I think the risk of that is much less. And what I always tell people is that the risks of surgery, there are risks to surgery, and those are taken up front, and they are at the time of surgery. The problem with epilepsy is that you are taking risks associated with the epilepsy that can be progressive for the rest of your life. And taking those all up front and potentially having the opportunity to reduce or potentially stop seizures compared to that of taking medication and less likely improving those seizures there is a significant amount of risk associated with that as well.
Yeah, and I also say that there's certain syndromes, certain conditions like tuberous sclerosis complex, hemimegalencephaly, some brain tumors, cavernous malformations, where we know with a very high degree of likelihood that seizure freedom will be very difficult to achieve with medication. So especially important if there's an abnormality on the MRI to consider surgical options.
Yeah, and then the flip side of that is if there's an abnormality, that gives it a higher chance to become potentially seizure-free with surgical options.
So there's many. So why? What are the risks of drug-resistant epilepsy? Why do surgeons get involved? Is because, especially in children, we worry about the comorbidities of epilepsy. So it's more than just seizures, especially for children that have a very important time window for development, especially the first 6 years of life. We know that seizures can be particularly harmful for their brain. And it's also not just the seizures themselves, it's that abnormal electricity in the brain while that child or that individual is not having seizures. So instead of using all that glucose, so the brain loves sugar, so all the glucose in the brain directed towards learning, focus, concentration, all those important tasks, that's going towards this abnormal electricity in the brain. So quite often, even after epilepsy surgery, when we get a good outcome, we hear from our families that now that I'm not worried about the seizures, I also notice that my child is much more attentive, much more, they can concentrate, they can get through a movie. There's all these secondary benefits of surgery. On top of that, we also don't know the risks of the medications to the growing, developing brain of a young child. A lot of them are kind of made to slow down your brain. And one of the possible benefits for some individuals, if they become seizure-free with medicine, is that we may be able to come off some of those medications as well.
And I think I can say this for all people who take care of epilepsy patients, is that we really truly understand that it is not just a disease for the patient, but it affects families, it affects social circles, it truly affects everyone who touches that patient. And so, offering these treatments, it is a very, very gratifying and it's one of those surgeries that we do when patients come back and, 5 years later, 6 years later, they're seizure-free, they have improvement in their quality of life, and it truly is something that is really, really important to us. So, yeah, both Dr. Fallah and I, we really care about epilepsy patients.
Yeah, and one of the things we don't talk about enough is epilepsy surgery can be life-saving. As some of you may know, some may not, there's a risk of SUDEP. SUDEP stands for sudden unexpected death as a result of epilepsy. On an annual rate, it's low, but it does add up over time, and especially high in those that have drug-resistant epilepsy, especially those that have nighttime seizures and those generalized seizures. So we know we have overwhelming evidence from many studies now that epilepsy surgery saves lives. Not only the resections that we're going to talk about, where we remove a part of the brain, but also some of the devices that we use that we're going to talk about, such as VNS, DBS, and RNS as well. And here are some of the numbers. So the 10-year survival rate with someone with drug-resistant epilepsy with just medications alone is 89%. That number increases to 92% when we add a vagus nerve stimulator. Not to say that the other stimulators will not add it. This study only particularly looked at VNS. And you can see that number get up to 98% with epilepsy surgery.
So there's essentially 4 different broad categories of surgeries that we perform. Resective surgery means that there's an abnormal part of the brain which is causing seizures, and that the goal of our surgery is to remove that and address that area of where the seizures start. We have various destructive treatments. The most common one we use is laser ablation. And what we do in those surgeries is we make a pinhole opening in the skin, and then we place a small laser fiber into the deep parts of the brain where we see the seizures coming from. Once we do that, we use an MRI machine, and we can, under direct visualization of the burning area and in real time, can monitor that ablation as it continues. Disconnection surgery is another type of surgery where we separate the 2 parts of the brain, either entirely or 2/3 of the right and left side, with the goal of treating a certain type of epilepsy. And then finally, we talk about neurostimulation, and we have vagus nerve stimulation as well as within the brain stimulation, specifically things like NeuroPace or RNS, if you've heard of those. So next step is to talk about what is the goal of surgery, and so why would we talk about surgery? What would be kind of the end game to that? Well, our goal, if we can do it, if we can safely, let's say we'll talk about resection for a minute. If we can safely remove a portion of the brain that is not causing, that does not involve important functions, so language, motor skills, those types of things, if we can safely remove that, we can potentially cure someone of epilepsy. And both Dr. Fallah and I have had very good success doing that exact surgery. Separately, we can talk about reducing seizures. And oftentimes, if we can get the seizures under better control, that can also be a significant improvement to the quality of life. And so if the seizures, for instance, come from a part of the brain that we can't necessarily remove, we can talk about neurostimulation, we can talk about other types of treatment with the goal that if we can reduce those, better control them, that would still significantly improve quality of life and, overall satisfaction, reduce depression scores, those types of things. There are essentially three types of surgeries that we talk about. So this kind of is a similar picture to what we talked about in the last slide. So resective surgery, what that means is that we make an incision on the scalp. Oftentimes we make a window in the bone, open the covering of the brain, remove a small portion of the brain. Again, not the part of the brain, this is specifically the part of the brain that's causing seizures or that we believe is the cause of where the seizures come from. We can also make a smaller incision and through a very small opening in the bone, perform various procedures to treat those seizures. And then we can also do neurostimulation, which involves even smaller holes where we place small electrodes into deep structures in the brain with the goal of treating the patient.
If you look at those images, these are pathologies or conditions that are best treated with resection. And there's various ones there. Not going to get into the detail, but typically the benefit, open surgery tends to be one of our most successful ways to permanently stop the seizures. And for many pathologies, you really need either you're addressing a large part of the brain, a lobe, or multiple lobes in the brain, or sometimes a whole hemisphere. And the best way to do that, there's different ways to do it, but in my opinion, the best way to do that is with open surgery. It's extremely safe. The benefit of open surgery as a surgeon is you see everything directly. Some of these minimally invasive surgeries are nice because you have a smaller incision, but you're trading off visibility and being able to see. It's different if you get a blood vessel that bleeds and you can't see it. Obviously, you're kind of limited in what you can do right away to help. But you can keep going.
Yeah, absolutely. I would echo everything Dr. Fallah said. I think that you just have, if there often, in the literature we know that if there's a lesion and we can safely resect that, the seizure-free rates do tend to be better than if there's not a lesion. Doesn't necessarily mean that we don't operate on people who don't have lesions. It just means that it's helpful for us to kind of better localize or focus our attention on an area of the brain.
So these are some of the pathologies that you may see that are typically what I say, they're surgical diseases. So cortical dysplasia is the most common cause of epilepsy in children that requires surgery. This is sort of an abnormal architecture of the brain that the child may be born with. And it doesn't cause any problems other than seizures, but unfortunately the types of seizures that don't go away with medication. Mesial temporal sclerosis is a very specific syndrome and condition, most commonly found in adults, which is a very specific part of the brain that gets involved in the middle part or the inside part of the temporal lobe that also responds incredibly well to surgery. Tumors, cavernous malformations or abnormal vasculature, blood vessels in the brain. And then some of the other conditions are more rare conditions like Rasmussen's encephalitis, which is an autoimmune condition, hemimegalencephaly, which is a congenital abnormality where one half of the brain is overgrown. Those tend to be kids that present extremely early in life with extremely common seizures and commonly require a hemispherectomy. Sturge-Weber syndrome, tuberous sclerosis, and encephalomalacia. So these are various conditions. And also, as Dr. Vadera said, sometimes we have non-lesional focal epilepsy. So just because the MRI is read as normal, it doesn't necessarily mean it's normal. The first thing on that topic, I actually want to say that these abnormalities can be extremely subtle. So even if, so at UCLA, for example, we have many academic neuroradiologists, some that focus on brain tumors, other people that focus on vascular abnormalities. But we want to make sure that our neuroradiologist who specializes in epilepsy is reading them. I can't tell you how many times we see an MRI that's been read as normal that's actually not normal. So all images are not the same, they're not acquired the same way, and all physicians reading them are not the same. So this is an area where I say you definitely need to get second opinion, sometimes a third opinion, and sometimes your options, your surgical options really change once you find that abnormality. But there are situations that even despite us getting the best quality scans and the best neuroradiologists reading them, there's still not a visible abnormality on the MRI. But even in those situations, we often have treatment options that are surgical.
Yeah, I would tell you that, and this is what I tell every patient that comes in our clinic, is that, oftentimes if you go see someone, they may give you very, very, difficult to hear, diagnoses, and they may say, there's nothing to do for this. And I've heard that story so many times where someone goes to a, community doctor, another hospital, and they're said, we can't do anything. There's no treatment for this. You're going to have to live with this. And I can't tell you how many of those patients we've been able to help. And it is incredible. And what I would tell you that I always tell my patients is that don't lose hope. Like, if a patient's coming to see us, we are going to work on it. We are going to figure out something that we can do. We are going to try everything in our arsenal, because I think that epilepsy is such a devastating disease, and it affects so many people around the person who has it, that we don't want to give up on patients. And I can't tell you how many times we've had patients who come in saying those things, and then we've been able to treat them. And some of those patients become seizure-free. Some of them get reduction in their seizures. But again, giving up, in my opinion, is not an answer. If it was me and or my family, I would just keep going to places, getting more information. I think what everyone's doing here is great. Coming to a place where you can actually get information and try new things, learn new things, absolutely the right thing to do. So this is a busy slide, but the important piece of it to say is that, it's kind of what we had talked about early on, is that if you fail 2 to 3 medications, likelihood of becoming seizure-free with medication alone, you can see, is extraordinarily low, 4%. On the other hand, in that same population of patients, if you can get a resection, if you can actually get the correct localization of the seizures and actually treat those, you have a 77% chance of seizure freedom in that same population of patients. So again, it's one of those things where it's worth continuing to research, going to level 4 centers, talking to people, seeing what other options are available. Really, really important.
So laser ablation is a tool, technology. There's a couple companies out here that offer it. What it basically is a minimally invasive way to address a small area of the brain that's causing seizures. So this is usually a tremendous option for, first of all, things that are visible on MRI. So it's typically, you don't want to do this in a non-lesional MRI where there's no visible abnormality. But it allows us to make a tiny skin incision. We place a fiber to...
Oh yeah, sure. Sorry. I tell patients that this laser fiber, I think, think of it like a guitar string. It's about the width of an actual guitar string. And when we do this surgery, we use a robot that helps us. So, with all of these surgeries we've talked about, 99% of the time you're asleep during it. That's one thing people always ask me, like, do I have to be awake during the surgery? Thankfully, you do not have to be. You are asleep during the surgery. We have a robot that helps us. We place a pinhole opening in the skin, and then we place these laser fibers into the deep part of the brain. And then, as I've mentioned before, we bring an MRI machine into the operating field I can actually see exactly where that fiber is within the brain. Then I can turn the heat on and then watch it as it ablates that tissue. And so we can be very, very focused and very, very exact in terms of what we're treating. The benefit of this surgery is that we're not injuring any surrounding brain. Oftentimes we're treating very deep parts of the brain. And so if we were to do this in an open surgery, you would have to, carefully move other parts of the brain. And even just by doing that, you can be injuring other parts of the brain. So with this laser fiber, we're able to really treat in a very focused way exactly where we want to treat it. This is just the picture. These are kind of some of the pictures you see. So the one on the right is the actual size. Like I said, it's like a guitar string, very, very thin. It makes a pinhole opening. You don't actually have to clip any hair to do that. People stay in the hospital overnight, and then they go home typically the next day. Other procedures, so there are many, many different newer treatments available. We don't have to spend a lot of time on them, but the main goal of these surgeries, just like the others, is to localize, treat the seizure onset. So these are all great procedures, and we can certainly talk about them to whatever extent you would like. So there is a very specific kind of seizure type where people tend to fall down. So what happens is that you have the seizure, you lose motor control in your arms and legs, and you fall down. And this is a very, very bad kind of seizure, as you can imagine. People hit their heads, they break their teeth, they get very, very bad injuries from this. And so one of the surgeries we can do is a disconnection. So as I mentioned before, the way I tell people to think about it is that your brain has two hemispheres, and there's a superhighway that connects the two. And what can happen often is that a seizure will start on one side, quickly go to the other side, and then once the entire brain is seizing, you can sometimes fall down at that time. If we disconnect if we stop that connection, that seizure is still going to go, but it's not going to go to the other side. And if it stays on one side, people don't typically lose their motor strength. They don't lose consciousness. They actually stand. We've had a remarkable number of patients that we've operated on either with open surgery or the laser, and have been able to help those patients as well. So again, a very, very good option for a certain type of epilepsy and a certain type of patient. This is corpus callosotomy, which is another surgery that we do, and often we'll make an incision on the scalp. I make a small window in the bone. Then in an open manner, I separate very carefully the two parts of the brain, and then I disconnect that corpus callosum again. Again, for the right patient, for the right population, this is an excellent surgery to do. Vagus nerve stimulation, again, another surgery that we can do. Oftentimes, if you cannot localize where the seizures come from in the brain, if we can't treat those with an intracranial procedure, or if it's generalized epilepsy, oftentimes what we'll recommend is putting in a vagus nerve stimulator as a next step in terms of our treatment. And what that means is we place a small battery. You can see that kind of in the left side of the chest. I have a small wire that you then tunnel into the neck, and then we very carefully find the vagus nerve, and I wrap that nerve with the wire. The benefit, as you can see here, is that in 50% of the patients, you can get a 50% reduction in seizures. People always ask me, like, well, how do I know if I'm in that 50%? And unfortunately, we don't have any tests or any way to know that. But in patients who don't have many other intracranial options, this is one of our good options that we can offer you. Responsive neurostimulation. So this is something else that we do pretty routinely at UCI. It is a great option for specific types of epilepsy. As you can see here, if you have eloquent cortex. So I always tell people is imagine your motor area is here. Let's say the seizures are coming from right around that same. So you have this kind of overlap between important motor structures and then your seizures. We can remove that tissue and potentially make you seizure free, but the side effect of that is not acceptable, which is weakness associated with removing that motor tissue. So then, up until about 12, 15 years ago, we had no options for that patient population. Nowadays, what we can do is we can implant a battery into the bone of the skull, I can implant electrodes right around the area where the seizures are coming from. And then similar to a defibrillator in the heart, it can listen for seizures, and when it sees a seizure start, it can send a shock and then either abort the seizure, reduce the length of the seizure, control it better. Really a great option for a large population of patients who in the past were non-surgical candidates. So if we knew that seizures were coming from a place like motor or language, or if it was coming from both sides of the brain, you can't remove both temporal lobes, you can't do, you can't do certain things. This has become a really great option for us as another option to treat patients. After the surgery, patients typically stay a day or two in the hospital. We leave the device off when I implant it. Every day we ask you to download the data. So they give you a laptop and a wand, and you place that over the device, and it downloads all that data. All that information then gets sent to your epileptologist where they can look at it, and then within a month or so they turn the device on, and then we go from there. Deep brain stimulation, we have several different devices to do that. There's really, kind of it's a great procedure as well for a very certain type of epilepsy. I think that might be the end of it. Does anyone have any questions about anything we talked about? Every institution has kind of their own focus and their own kind of bias towards it. At UCI, what we do is if I can localize a lesion, if I can find an area that I can potentially remove, or if I can, find an area that I can't remove, but we can do neurostimulation directly to the brain, we will go for that. If a patient has seizures where we cannot localize them, we're having difficulty, then oftentimes DBS or RNS to the deeper structures are a good option.
Yeah, so there's no good answer. There's actually no head-to-head studies, DBS, RNS, or VNS. Anecdotally speaking, the field is moving a little bit more toward intracranial stimulation as opposed to vagus nerve stimulation. We, again, at least us and maybe Dr. Vadera as well, we think it's more effective than the vagus nerve stimulation, but again, we don't have head-to-head studies. Yeah, so DBS is, again, good for general, if it's multifocal, generalized. RNS, you can use it in the same way where you're targeting a deep part of the brain, but it's also used on the surface.
Yeah, so yeah, it's like a really, so the RNS is nice because it can give you both surface level treatment. So along the, like we said, if there's like motor or language or some area I cannot resect, you can stimulate that. If you're not able to localize exactly within the brain where it is, you can still put it in the deeper structures and then also get good relief as well. So we're kind of skewed more towards RNS, but I don't think there, as Dr. Fallah said, there's no real right answer to that question. I don't think I've seen many patients with both. So this talk, I'll tell you one thing that we did not talk about at all in this talk is diagnostic procedures. I think that's a major piece that I wanted to bring up at the beginning, and now that we're at the end, I thought it was a good time to talk about it as well. So in epilepsy surgery, we have two broad categories. So we've talked quite a bit about therapeutic surgery, resection, laser surgery. The goal of these surgeries is to treat, stop the seizures, reduce the seizures. There is a second very large category, and a lot of patients that we operate on as well, where we're doing diagnostic procedures. And that means implanting electrodes either on the surface of the brain or depth electrodes into the deep parts of the brain, listening for where the seizures are actually coming from. And so, to answer your question, just like anything else, if a patient had multiple lesions, like, TS, for instance, tuberous sclerosis, you can implant multiple electrodes and then better localize within the brain tissue itself where the seizures come from. So I always tell people, these are our electrodes, and I capture a seizure, and I see that all the seizures come from this electrode. That has changed the entire, our understanding. So rather than putting scalp electrodes where we have these stickies on the skull, on the skin, if you have all these electrodes up here and you have a seizure from this point, and the seizure goes to all those electrodes, you really don't know where along the surface, like where the deep part of the seizures start. If I put these electrodes in and I see that every seizure comes from this one electrode. Well, now I've actually, localized it exactly. So, sorry, we didn't really mention a lot of that, but that would be the answer to that question. I would say that it's a great example we talked about at the beginning, which is that if you've tried multiple medications, you feel like the people that you're working with are not helping you, or you've kind of hit a plateau, absolutely that is a time to go find a level 4 epilepsy center near you. Find a good epilepsy neurologist, so not just a neurologist, but someone who specializes in epilepsy, and then have that person start the workup. And that workup, a lot of times patients are on the wrong medicine entirely, so then they get rid of those meds, they actually change the meds, and then seizures get better. Or they say, you know what, that's not going to work, let's think about surgery. So I think that's what would be my recommendation.
I was just going to say, I was at an event recently, and we kind of almost take it for granted when we're at these big academic centers. We have a huge amount of support. And sometimes the community physicians are trying their best, but their resources are very limited. They need to have access to a neurosurgeon. They need to have access to a neuroradiologist. And not only that, you need to have people that focus on this. So, for example, myself, Dr. Vadera, my entire practice is focused on epilepsy. And if you don't do that, it's hard to, when you are faced with a patient that has a more complex problem and you don't have resources, it's actually hard to get them to the right treatment. So I echo what Dr. Vadera says. We, as challenging as your particular situation is, I want to tell you that challenging cases are the norm of what we see.
Yeah.
So
what you're describing is a very, very good candidate for some sort of evaluation. And then whether that evaluation leads to surgery, I don't have imaging or anything to discuss, but I would absolutely tell you that we have, at UCI, we mainly treat patients 14 and up. I trained in peds, but I mainly do adult surgery. I've had patients who had these types of problems their whole lives, pediatric problems. They grow up and they continue to have seizures, and we do these surgeries, which are considered mostly pediatric surgery, and we've had many, many successes. Patients become seizure free. So, absolutely, it's a great candidate, at least to be evaluated.
So when the MRIs show cerebrospinal fluid, it's actually infarcted tissue. So there's still tissue there. The MRI doesn't show it when it's infarcted. So it's usually gliotic infarcted tissue. But to your point, it doesn't cause any issue, or it doesn't really impact the epilepsy surgery treatments. Just some general thoughts is just because there's an ablation or there's an RNS doesn't mean that another workup will not, result in a different recommendation. Sometimes if the device is there, maybe it's not optimized. Maybe we need to do different things with the device. Maybe we need to move the leads. Maybe it's not the right device. So a little bit too complex for me to give you anything specific, except if you still don't have good seizure control, just to get another workup. And sometimes more than one device, you get this synergistic relationship where 1 + 1 = 3. Sometimes these devices work better together. And I know these devices all sound the same, VNS, DBS, RNS, but they all work very differently. And just because one has responded to one type or not doesn't really predict how they do with the next device.
Yeah. And just to add to that, the biggest thing I'd recommend is that it clearly is, a challenge that you're having. It's clearly something that you want to address, and the best way to do that is find another opinion. Don't lose hope. Continue to fight. Try and find a place that can help you and treat you. If you go to another level 4 center, they can't treat you, go to another one. I mean, if it was me, I would just keep trying, because it's not a life to live if you're struggling with these types of problems every day, and especially because there's things that new things that come out all the time. So aside from the fact that we have great treatments we talked about, there's new ideas, new treatments, and all sorts of things that you can see in different centers. So definitely recommend continuing the journey in there.
Over time, the more seizures that the brain sees, that leads to atrophy, what means shrinking of the brain. And you really want to try to address the seizures before that happens. As neurosurgeons, unfortunately, we don't have interventions to fix the brain. Everything that we're doing is directed towards preventing decline, preventing further damage. So time is important. So the sooner you get to intervention, the better it is.